1, 2. So we are online. We will be waiting until 00. 1, 2. Please leave a message in the chat if you are online also, to know with whom we are organizing the class today. So let me know if you're online. Hi Lucas. Okay, any other participants for today's session? Okay, we'll wait until 05. Only Lucas is joining the chat. Do we have other students? Please let me know in the chat who is online. Okay, so once again, I want to say to you that David Ha, hello. Okay, so we have also David Ha. We'll call you David. Is it okay with you? Okay, in 5 minutes we will begin the course. Thanks for the confirmation, David. If in the meantime there are other viewers and participants, please let me know in the chat section. Three minutes and we will start the course. Okay, thank you, Lucas, for reposting. Okay, I hope David is with us also. So let us know, David, if you are also ready to start the course. Okay, so let's go on. Lucas and David, are you leave a chat, something in the chat to so that I know that you are online. Okay. Today we will discuss surgery and infectious disease. We'll start with the first clinical case, a surgical case. We have a 32 years old male that comes to the ED after a motor vehicle accident. His vitals are 37 degrees Celsius, 142 beats per minute and 80/48 blood pressure. On the abdomen there is a seatbelt sign. The patient has confusion with a Glasgow Coma scale of 12. The abdomen is tense, however there is no abdominal pain and there is also no abdominal rigidity. What is the best next step in this patient's management? Do a diagnostic peritoneal lavage, do a CT abdominal scan, perform a fast scan, or do directly an exploratory laparotomy? Please let me know your answers in the chat. Okay, so we have starting with a fast scan. David, do you have another perspective? Also, Lucas, could you tell us why do you think the fast scan is the right answer? So, do we know why the fast scan is the one? Okay, right, Lucas. Let's discuss a bit the options. So, the correct answer is indeed a fast scan, as the patient has a blunt abdominal trauma. There are no signs of peritonitis, namely rigidity or pain, and the patient is unstable. Therefore, he should undergo a fast scan. If we consider all the answers, a CT abdominal scan can be considered if the patient is stable. an exploratory laparotomy is used if there are signs of peritonitis, such as rigidity with abdominal pain, and the diagnostic peritoneal lavage could be used if the fast scan is unavailable or if the fast scan is unequivocal. Now, when we have such questions on the boards, there is a certain algorithm to apply for the blunt abdominal trauma. Namely, in patients with blunt abdominal trauma, we assess firstly for signs of peritonitis. If there are signs of peritonitis, this is an indication for exploratory laparotomy. However, no peritonitis means that we analyze the hemodynamic state of the patient. If the patient is unstable, we proceed with a fast scan. A positive fast scan is an indication for exploratory laparotomy. Further down the diagnostic tree, we have a negative fast scan that has two options. When there are signs of extra-abdominal bleeding, such as bleeding from the limbs, then we manage accordingly, for example, applying a tourniquet. If, however, there are no signs of extra-abdominal bleeding, we proceed again with exploratory laparotomy. By contrast, when the fast scan is unequivocal or it is unavailable in the emergency department, a diagnostic peritoneal lavage will substitute it. On the other hand, if the patient is stable, we perform a CT abdominal scan. Okay, so are there any questions on this case? David, Lucas? Okay, so Lucas, you do not have any questions. Now, David, I think he disconnected, maybe. Okay. Now, let's go down further the line and proceed with the next case. We have a 19-year-old male this time that has received a bat swing in his face while playing in the local baseball championship. In the emergency department, the patient complains about orbital pain. Also, he states that everything is double. When asked to fixate the doctor's finger, his downward gaze is impaired. What is the best next step and the most probable diagnosis? CT scan of the head with retroorbital hematoma, CT scan of the head and blowout fracture, MRI scan of the head and blowout fracture, or CT scan with orbital compartment syndrome. Let me know your answers in the chat. Okay, Lucas, why do you think it's B and not the other ones? David, do you have any input on this situation, or if we have new participants, please let me know in the chat also your answer. Okay, so Lucas has a correct point on the blowout fracture. Shout out to him. Indeed, it is a blowout fracture. The CT scan of the head is to watch for any herniation or muscle entrapment, namely because the inferior orbital floor can be damaged and nerves as well as the muscles can be entrapped in the area of the maxillary sinus. Now let's discuss the answer. The answer is B. The patient has a blowout fracture and requires a rapid imaging technique to assess for severity, CT scan. How would we proceed in analyzing this vignette? Both retroorbital hematoma and orbital compartment syndrome are complications that can be seen in a blowout fracture. A retroorbital hematoma may be responsible for the patient's diplopia since he sees everything double. We have no sign of orbital compartment syndrome, which usually presents with a rock-hard eyelid. On the other hand, the differential between B and C as an answer is made by the convenience as well as the rapid implementation of the imaging technique. Namely, an MRI scan, it will take more time and it is more costly than a CT scan. A blowout fracture is a fracture of the orbit. It usually presents with extraocular muscle and nerve entrapment, especially the inferior rectus muscle, as in this case when the patient cannot look down. The muscle entrapment also is responsible for an oculocardiac reflex activation. Activating this reflex will lead to severe vagal symptoms such as bradycardia. As I've told before, an orbital compartment syndrome is usually presenting with rock-hard eyelids. How do we treat the blowout fracture? The blowout fracture is treated with surgical drainage of the retroorbital hematoma that might cause the orbital compartment syndrome. If we have entrapped muscles, this is an emergency. Surgical decompression is required in this case. And if the patient is severely bradycardic due to the ocular cardiac reflex activation, then we administered atropine. Do you have any questions on this particular case? Okay, thanks Lucas for the input. Thank you. Do we have other participants? As the stream fluctuates and I do not know if we have other participants that would like to engage in the chat. Okay. Let's proceed further with a break, and this is the time to acknowledge Ambas, who gave us a little bit of support. They recommended one article that will help us prepare for the statistically harder subjects for Step 2CK. I will let the link in the chat, not only in the description, so you could take a glance, and maybe this article will help you to get a great score at Step 2CK. Please let me know if you have received the link in the chat. Thank you, Lucas. Yes, me too. I also love Ambus and their products, and as I mentioned before, if the class were to be 25, were to be of 25 students, we were invited to participate in a discount offer for their products. Okay, so are we ready for the next two cases? Actually, there are three. Okay, going to the next one. We will have two vignettes with the same answers, a clinical vignette that is usually seen in Step 2CK. We have a construction worker of 48 years old that is saved after a heavy bar fell onto his right thigh. On the expression of the thigh, he has a right crural lump. According to his colleagues, this crural lump expanded continuously from the moment of the accident. Now he is in the ED. At palpation, the popliteal pulse and the pedial pulse are absent. The patient is stable hemodynamically. What is the best next step in this situation? We perform an emergent surgical exploration. We perform a CT angiography. We perform a 24-hour compression for resorption, or we perform an amputation. Okay, so we have an A. Do we have other answers or opinions? Okay, so let's go to the next clinical case. This time we have a female of 65 years old that falls from her height. She states that she bled previously at the level of the right antecubital fossa and applied rigorous pressure. The bleeding stopped. The patient now is stable hemodynamically. However, we have a Freddy radial pulse on the right. On the left, the radial pulse is well perceived. What is the best next step in this case? Emergent surgical exploration, CT angiography, 24-hour compression for resorption, or amputation? Okay, Lucas, so why do you say that the 24-hour compression is recommended in the second case? Or why it is B? It is in the clot. Okay, so you say that we will go with a CT angiography to see if there is a clot or not. Okay, so Lucas, you answered well to both questions. However, the reasoning is a little bit different. It's not that we choose to do an emergent surgical exploration due to a compartment syndrome, but rather that we have hard signs of vascular injury. On the other hand, we choose to do a CT angiography to the female patient due to the fact that she has soft signs of vascular injury. Let us see the answers. So the first one is indeed an emergent surgical intervention, whereas the second one is a CT angiography. Why? Well, in the case of vascular injury, we have hard signs and soft signs. The hard signs are represented by the 6 P's: pallor, paresthesias, poikilothermia, meaning that the limb is now colder than normal. There will be pain, pulselessness, and pallor of the limb. Other hard signs of vascular injury are a palpable frill, an expanding hematoma, and absent pulses or active hemorrhage. In the first case of the male, the patient had no pulses at the level of the pedial artery or at the popliteal level. Also, his co-workers stated that the crural lump has expanded, namely his hematoma expanded. So this patient had 2 hard signs that indicated a need for emergent surgical exploration. On the other hand are the soft signs. These are a large non-expandable hematoma, a history of the bleeding at that site, a peripheral nerve deficit, which could be translated by paresthesias in this case, but it is an isolated finding. The pulses are still palpated, however, they are diminished or unequal. Or we can have a complex fracture. This was the case of the female, who had a history of bleeding at the level of the antecubital fossa and a Freddy radial pulse, namely it was diminished. We could also consider that she had a complex fracture, but there were no details in the vignette that would indicate this third finding. In the case of soft signs with vascular injury, the next best step is to perform a CT angiography. Okay, so let me know in the chat if you have any questions regarding how to solve the trauma-related questions for the vascular compartment. Lucas, I'm pleased that now is more clear. That is clear for you. Yes. The reasoning was a little bit off, but in the end, the answers were right. Okay, now let's go to the last vignette of the day. Namely, we have a businessman. He returns to US after a holiday in Africa. In the ophthalmology unit, he has a teary eye, redness, mucopurulent discharge. At the examination, we have an eyelid with follicular conjunctivitis. What is the most appropriate treatment for the patient? We give him ceftriaxone, we give him azithromycin, we perform surgery for resection of trichiasis, or we give him clindamycin. Okay, so we have an azithromycin thinking it's chlamydia. Well done. Serotype 8K. Okay, Lucas. Okay. The correct answer is indeed azithromycin. We have a trachoma that is usually treated with azithromycin. However, it is important to lay out a bit the different aspects of Chlamydia trachomatis infection. Trachoma is caused by Chlamydia trachomatis by the A to C serotypes. There are two types of trachoma. We have an active trachoma. This one is usually seen in neonates, is usually asymptomatic, but it can be asymptomatic with inflammation and follicular conjunctivitis. To treat this prophylactically, neonates are given erythromycin ointment. On the other hand, we have scarring trachoma. This one leads to blindness and is typically seen in adults. It has to be in an endemic area such as Africa, Asia, and Latin America. It has two principal complications. It can present with entropion, meaning that there is an inward eyelid rolling, and trichiasis, the abrasion of the eyelids directly on the cornea. The diagnosis is made on the clinical presentation, namely mucopurulent discharge, red eye, teariness. Also, we can have a sensitive and specific method to diagnose the patient with NAAT. However, once we have the clinical findings, and also in the case of the scarring trachoma, we know that the patient comes from an endemic area, we go to the treatment. The treatment is represented by azithromycin. However, if we have those abrasions of the eyelids, we have to do a surgical intervention. Namely, we will separate the eyelids from the cornea. Do you have any questions on Chlamydia trachomatis? Yes, Lucas, indeed. This is the most common cause of blindness in Africa. Do you know other causes of blindness in Africa? Loa Loa. So, question: what is how is actually diagnosed a Loa Loa infection, Lucas? Exactly. There are worms that migrate on the surface of the eye, but it does not cause blindness. Rather, again, teary eye with redness. Exactly, ophthalmoscope. So another common cause of blindness in Africa is represented by infection with Onchocercus volvulus, causing onchocercosis. And a viral conjunctivitis usually does not cause blindness, hopefully. The most common viral conjunctivitis is seen in the developed world with adenovirus. Okay, so Lucas, thank you very much for being part of the class and for the interaction. I hope you had a lot to learn. Hopefully there will be more students next time to interact and to learn with them. Now, do you have any questions? Okay, so now I will share with you the form, the Google form. This is for feedback, and also if we were 25 for the Ambas discount. I will share it also on Reddit. Maybe other participants will be interested. However, I cannot guarantee that if they are not on the live session that we could address this. Okay. What else could I say? If you liked it, please recommend it to other students. Also, you can access the form in the description below in order to access the Ambas discount, and as well as improving the quality of this podcast / live stream. Okay. So, Lucas, did you receive the form also? Thank you also for being here and for helping spread the word of this live stream. Maybe this live stream will grow with time. And I hope you have a nice day ahead. And we'll see each other in 2 weeks, hopefully in a great number. Okay. Have a nice day.